Hi, at the outset, I would like to thank the organizers, especially Dr. Bansi Sabu, for giving this wonderful opportunity to take the science forward. My disclaimer and conflict of interest: I represent the pharmaceutical industry, but my bias would be limited for the simple reason that I would share only the evidence-based recent perspectives that what has happened in 2014 and this part till 15, and how diabetes probably would change, how it would impact down the line. Looking from an epidemiological trends from the benchmark of US, which I consider as the hallmark in terms of evidence-based documentation, this is the current recent most data from CDC, which clearly documents that there has been a drastic increase even in US as far as the rise in diabetes is concerned. 8 million people of this are unfortunately undiagnosed. We can imagine the state in our country and what we need to work on. Similarly, this was a very interesting paper published just recently, which talks about an extrapolation of the data from NHNE survey, which actually included different parameters incorporating FPG and HbA1c. Out of 28 million US adult diabetics, only 3/4 are actually aware of the diagnosis, which probably would be a surprise for us. And one interesting learning which came along was that diagnosed patients are more likely to have LDC below, LDL cholesterol below 100 milligram per deciliter than undiagnosed. So probably diagnosis confers opportunities to treat the other cardiovascular risk factors, despite the fact 25% are still underdiagnosed. An interesting analysis which was shown in this study was that patients who are well diagnosed also have a better control down the line in terms of, although a small number, but they are also the one which have the best control, not only in just diabetes, but overall holistically with respect to other cardiovascular risk factors and other modifiable risk factors as well. I think we need to implement such a model as far as the diabetes management in our country is considered. What I called is that the AEE model, assessing the awareness, engagement, and effectiveness of prevention, which actually closes a paradigm and starts a new dimension altogether, right from engagement of the patient, diagnosis, care processes, and ultimately transforming into a better outcomes overall. Recent most recommendations as far as US preventive task force is concerned, that high-risk patients need to be screened, wherein the net benefit of screening is possibly moderate. Why this has come now? For the simple reason that as far as 2008 review was concerned, there were insufficient evidence for measuring blood glucose in asymptomatic adults. So based on the this analysis is based on, recommendations are based on the recent lifestyle intervention studies and longer follow-up on 4 studies from the earlier review. So basically evidence-based translating into stringent recommendations based on the premise that the risk is defined for the fact that patients who are more than 45 years old, obese, having a first-degree relative with diabetes. Interestingly, screening did not show any improvement in the cardiovascular morbidity and mortality despite a long follow-up. And indeed, drug therapy to prevent diabetes carries only a small to moderate harms altogether. I would call, in last 15 to 18 months, we have seen a lot of landmark publications which have been strongly in the medical media, which talks about type 1 diabetes. And it would not be wrong to call this last couple of months, as type 1 diabetes has evolved not only from just epidemiological trends, outcome data, and new technologies also. This is one of the interesting paper in that direction, which highlights that type 1 diabetes can expect to live 13 years fewer than their non-diabetic peers as far as the mortality perspective is concerned. Parallelly, there was another study which has shown that intensive treatment could extend life in such patients. This was based on the Scottish registries, where expectancy for all adults with and without type 1 diabetes between 20 or above 20 years of older than 20 years of age between 2008 and 10, despite the fact the evidence level was relatively less because this was from the registry data. Nonetheless, as an observation, it would show a path how type 1 diabetes need to be managed down the line. Parallelly, what I was referring to, the study wherein 14,000 adolescents and young adults with type 1 diabetes who had initially received 6.5 years of intensive versus conventional therapy in the DCCT arm trial looked very closely, and follow-up of 27 years had shown that mortality was significantly lower among those who had received intensive versus conventional therapy. An interesting editorial which accompanied these studies highlights that, yes, we are doing well, pretty well as far as type 1 diabetes therapeutic approaches are concerned. But beyond this, we need to look for, certain genetic factors, biomarkers related to risk of diabetes complication, and especially diabetic nephropathy, where we need to accelerate as far as research and development is concerned. So nonetheless, there continues to be an inadequate access to advanced diabetes technologies, education and support from healthcare professionals, and at times even family encouragement, which all need to improve. And this is from an advanced country setting perspective. We can easily extrapolate this to our setting. The evidence, it would be grave. Men versus women, probably women do not fare well as far as the mortality outcome data is concerned with respect to type 1 diabetes. This was based on the 26 studies that reported mortality rates in type 1 diabetes versus without. There were 2 lakh participants and 15,000 deaths which were included in this analysis. Individual to individual comparison, as far as the standardized mortality ratio was concerned, it was 5.8 versus 3.8 in women and men, which actually translated into a 37% higher excess mortality risk in diabetic women versus men. And this was not much different from the excess risk with respect to CHD or in general with cardiovascular disease. So it has been postulated that because of the poor hyperglycemic control, which is often noted in women, and also disturbances in the hypothalamus pituitary ovarian axis, could result in such outcomes, which still remains a speculation. And interestingly, in NAGM very recently, we saw this paper that even well-controlled type 1 diabetes are associated with increased mortality risk. And in fact, they have graded the HbA1c levels with the risk factor as far as mortality is concerned. This was a landmark paper from a technological perspective as far as the bionic pancreas are concerned, a new dimension which is emerging, that there might be some improvement as far as be it mean plasma glucose or maybe scheduled mean plasma glucose is concerned with this newer technology, which would take still little more time to emerge, but definitely a new direction. Metformin for diabetes prevention, I think this is a debatable, controversial element, but what has been deciphered in this BMJ paper, that possibly or maybe with a lot of ifs and buts, at the highest risk scenario, patients may have some benefit. This was the recent analysis from the DPP study, wherein 3,000 patients at risk for type 2 diabetes were randomized to metformin, lifestyle intervention or placebo, and were divided into different quartiles based on FPG, HbA1c. 3 years follow-up with metformin were associated with a 21% absolute risk reduction, and NNT to prevent one case was 4.6, which seems to be very promising in that subgroup. And patients in lower quartiles actually experience not much benefit. So overall, the implications could be that we might decrease the over-treatment in that subset of patient population and make prevention of diabetes far more efficient, effective, and a patient-centric approach, as what is being recommended in some of the guidelines as well. As far as type 1 diabetes management in children is concerned, it has been lowered. The target recently has been lowered to 7.5, with respect to which was earlier 8.5. We have been knowing about the glycemic index, the importance of glycemic indices, but this was a contrary paper which came up very recently, which has cross-compared across different subset of patient population, wherein 160 overweight adults were assigned to 4 different categories under randomized control setting with respect to low glycemic index, low carbohydrate group, another was low GI, high carbohydrate group, high GI, low carbohydrate, and high GI and high carbohydrate group. Although it was not for a very long time, but definitely an interesting study design, and closer to a realistic perspective that all diets were low in saturated fat and including substantial amounts of fruits, vegetables, and low-fat dairy foods. So basically, it did not suggest any major benefits associated with the low glycemic index, what we have been believing so far. In main comparison, the extreme group, the low GI, the low carbohydrate diet, when compared with the high glycemic index and high carbohydrate, interesting finding was that triglyceride was significantly reduced, but no significant effect on insulin sensitivity or blood pressure, systolic blood pressure, or LDL or LDL cholesterol. Implications are very simple, outright, and clear that the concept of glycemic index is less important what we have been believing, and these findings should therefore direct attention back to the importance of maintaining an overall heart-healthy lifestyle, including the diet pattern. So the wheel turns around basically. This was again just a glimpse of a very interesting paper which has been strongly in the medical media as well, that high energy breakfast combined with a low energy dinner could help blood sugar better than versus a low energy breakfast and a high energy dinner. So interesting dimension which are consistently on. As far as a new technology, this was in Nature Review, Nature Communication, which was recently published. An exploration, that how glimepiride can be sensitized with a different technology, the blue light impact factor, which can actually trigger the pancreas at that point of time to release glimepiride and make more efficient release of insulin from the beta cells. Still premature, still experimental, but a powerful thought, as I may call it as. This is again a very emerging topic, that dental health and diabetes and the cardiovascular health. What are the association and the factors which has been demonstrated? So one of the study recently had demonstrated that dental care may be more effective route to diagnose diabetes rather than the regular primary care. The blood of gums could be an easy way of dentists to test if blood glucose is too high. An extreme paper, but nonetheless a new dimension. Glimpses of certain other research which has been active over last 1 year, that vigorous exercise is associated with improved glucose tolerance, although in a small subgroup of patients, but very effective as far as impact on abdominal obesity and glucose tolerance in specific obese adults is concerned. Healthy lifestyle before pregnancy might prevent gestational diabetes, another new dimension which has just recently emerged. Blood glucose levels might predict the risk for pancreatic cancer. Probably the timing with the Steve-Jobs factor associates that. Some of the news from the FDA, certain technologies, certain dimensions, diagnosis versus newer approaches, which is just very recent. The Cronus transporter 8 autoantibody test has just been recently been approved as far as type 1 diabetes is concerned, wherein they have, the basis for the approval was that antibody in 65% of blood samples from patients diagnosed with type 1 diabetes, and also the false positive results from other kind of diabetes or other autoimmune diseases was less than 2%. But nonetheless, negative results do not rule out or exclude the diagnosis. Rapid approvals for two new monoclonal antibodies as far as diabetic retinopathy is concerned. Very recently, this year, we have seen new dimensions emerging in diabetic macular edema. This was again a very recent FDA warning that multi-dose diabetes pen should not be shared, possibly because it could potentially spread the infectious disease like HIV and hepatitis. And this is a change of perspective from 2008 versus now. Technology going overboard. A new app has been technically being approved by US FDA, but nonetheless, limitation remains. It should not be a substitute for standard at home as far as blood glucose monitoring or a primary display device is concerned. But the reason for its approval has been that it gives a glucose monitoring picture in real time to the caregivers at a distant geographical location, especially for parents of children with diabetes. So virtual technology might overrule. Where does diabetes stand as far as management of diabetes, as far as the reducing the overall global cardiovascular disease burden is concerned? Looking from the 2025 statement that we need to reduce the premature cardiovascular mortality by 25% by 2025, where India is also a signatory to the WHO. As far as diabetes is concerned, the prevalence should be 0. We should stop the increase in the no new diabetes cases should be actually be diagnosed, or we should curtail the growth of diabetes. Only then it would contribute effectively that 25% reduction in probability of premature death between ages of 30 to 70 from the 4 major non-communicable diseases is concerned. But what still remains even bigger challenge than diabetes in that perspective would be the prevalence of tobacco use, which need to go significantly lower what it is now. This was a very recent paper, just a couple of days back, that historically a good review, good thought, wherein why we have not seen insulin as generics globally, but nonetheless what it highlights that because of various patent and other roadblocks, this journey has been inconsistent. But nearly a century after its discovery, there is still no inexpensive supply of insulin for people living with diabetes in the advanced countries, be it US or Europe. US is still not clear about the various guidelines as far as the regulatory approvals for biosimilars is concerned. But nonetheless, it creates a strong need that how the regulatory pathway has to be accelerated to have good quality biosimilars consistently. This was one of my papers recently at ADA, looking into the association of bladder carcinoma and the risk of bladder carcinoma with pioglitazone. Lower level of evidences which clearly came out as far as this analysis was concerned. Of course, we could not have prospectively designed studies for such a risk, but nonetheless, implications for our own setting, Indian setting, might not be very clear because the risk for bladder carcinoma inherently is very much low as compared to other carcinomas in our population. Thank you very much for the patient listening.